You may see a second one for streaming. Got it. Okay.
Yes. Got it.
Just a second. And we are live on YouTube. And I will go ahead and
Hi, my name is Bill Wilkerson. I'm a data analytics and biochemistry student. I'm really excited to be here tonight as well. Dr. Shah, the mic is yours.
Thank you, Dr. Shah, the integrated medicine physician based in Seattle. So happy to be here. Thank you.
Hi, everyone. Over to you, Joey.
Sorry, guys. I think Muskan is here now. So that means the speaker is here. I'll be passing the mic on to Muskan.
So hello and welcome to MedNews Week conference, where we aim to bring you the most cutting-edge information from medicine's global leaders. I am Muskan Joshi and I will be your host for today. Before we begin, I would first like to acknowledge the incredible team that helps us make these events a reality. Our founders are two internationally recognized researchers, Dr. Jan Leifman and Dr. Chandler Park, who is also the president of Kentucky ASCO. Our chairs include Dr. Park, Dr. Leifman, and Pratisha Ghanta. Our organization committee is comprised of Alexandra Van de Kieff and Yavuz Selig. Our managers include William Wilkerson, Pallavi Pai, Gayatri Menon, and myself. Our educational committee includes Sean Jakevitz, Amar Al Shamon, Shubha Pawar, Janvi Shah, Madhuri Balasubramaniam, Harshal Chaurya, and Astha Naik. The moderator for today's event is Madhuri Balasubramaniam. Now, I am excited to introduce our wonderful keynote speaker, Dr. Anant Madabhushi. Dr. Madabhushi is an internationally recognized leader in computer-aided diagnostics corresponding with oncology and pathology. He is the director of AI and precision medicine at Emory Winship Cancer Center and professor at the Wallace H. Coulter Department of Biomedical Engineering at Georgia Institute of Technology and Emory University. Prior to joining Emory, Dr. Madabhushi was at Case Western Reserve University, where he was the director of the Center for Computational Imaging and Personalized Diagnostics and Donnell Institute professor, Department of Biomedical Engineering. He was also a research health scientist at the Louis Stokes Cleveland Veterans Administration Medical Center. He is a globally renowned innovator in using computer vision for detecting neoplasms with radiologic and pathogenic features. Dr. Madabhushi's team is involved in developing and applying novel AI for the diagnosis, prognosis, and prediction of therapy responses for a variety of diseases, including several types of cancers, cardiovascular disease, kidney, and eye diseases. Dr. Madabhushi has more than 100 patents in medical image analysis, computer-aided diagnosis, and computer vision from renowned organizations including the NIH, NCI, NSF, US Department of Defense, and many more. He is an internationally recognized researcher with over 450 peer-reviewed journal articles and conference papers in prestigious journals including the Nature and Lancet. He is also a sought-after lecturer who has delivered more than 375 presentations across the world. Dr. Madabhushi is a fellow of the American Institute of Medical and Biomedical Engineering, a fellow of the Institute of Electrical and Electronics Engineers, and a fellow of the National Academy of Inventors. In 2015, he made Crain's Cleveland Business Magazine's 40 Under 40 list. And in 2019, 2020, and 2021, he also was named to be the Pathologist Power List, a list of 100 most inspiring professionals in pathology and laboratory medicine. And he has mentored over 100 successful trainees in all stages of training and received the Dyakoff Award for Distinguished Graduate Student Mentoring at Case Western Reserve University in 2020. In 2019, Nature magazine called him out as one of the 5 scientists pursuing truly off-beta and innovative approaches in cancer research. And most recently, Dr. Madabhushi has been awarded 2 prestigious R01 grants from the NIH to pioneer novel AI-powered diagnostics for solid tumors. And additionally, last week, he was recognized as the #1 most productive and top-cited author globally in AI-based tumor pathology research. And we are incredibly fortunate to have him today with us for today's session. And with that, it is my pleasure to welcome Dr. Madabhushi. The floor is yours.
Well, thank you for that very, very kind introduction, Muskan. And thank you, Jan. And thank you, MedNews, for hosting me. I have to admit that after that very flattering introduction, I'm a little concerned that the presentation might not live up to the billing that I was just provided, but I'll do my best. Firstly, I just want to acknowledge the tremendous work of the wonderful students, scientists, postdocs, and faculty colleagues that I have the pleasure and honor of working with. Previously at Case Western Reserve University, but more recently, given our transition to Atlanta, now at Emory University and also the Atlanta Biomedical Center. And so for today, I want to talk about the concept of artificial intelligence across different length scales for precision medicine. I've very intentionally titled the talk Interpreter of Maladies, a play on the title of the book, Emperor of Maladies, a fantastic chronology of cancer by Siddhartha Mukherjee. And while Siddhartha's book really focused on the history of cancer, I think in many ways, AI is the interpreter of maladies, and hence the title. I want to quickly just do an acknowledgement of my conflict of interest. As the saying goes, no conflict, no interest. So we're happy to be working with a number of different entities to be able to move some of the discoveries we're making in the lab out to clinical translation and for deployment. Just want to call out Picture Health, which is a company that I recently co-founded, and I've got an equity stake in that company as well. However, if I'm being completely honest, I will have to disclose that my true disclosure is the fact that I also have a social media account. I'm on Twitter, that's my social media handle. And if you are on social media, and if any of what I present in the next 45, 50 minutes is remotely appealing, please feel free to give me a follow. So I want to set the stage a little bit and talk about why AI for precision medicine is so important. And even though I use the example here of cancer to convey the importance of AI as a precision medicine tool, it's important to understand that the utility of predictive tools, prognostic tools, really spans many, many different diseases outside cancer. But cancer is a really great example where 40% of the adult population in the United States would be diagnosed with some form of cancer in their lifetime. It's a great example to showcase the need for thinking about precision medicine, the need for thinking about prognostic predictive tools. So I think even about 10 years ago, one would have regarded a cancer diagnosis more like a death sentence than anything else. But when you look at the statistics, you look at the fact that 40% of the adult population is being diagnosed with cancer in their lifetime. But when you actually look at the mortality on account of cancer, it's no more the kind of death sentence that a diagnosis of cancer used to convey in years gone by. Because there is a huge discrepancy between that 40% diagnostic incidence rate in all Americans versus a mortality which is about 600,000 deaths per year. Now, I don't mean to belittle or trivialize 600,000 deaths because of cancer on a yearly basis. It's still a very significant number. But clearly, there is a discrepancy between that 40% diagnostic incidence rate and the 600,000 deaths. And the question, therefore, is why is this so? Why is there that discrepancy? And certainly, there are few compelling reasons to suggest this. One, the fact that we've become more aggressive in the way we are screening for a number of different cancers. We are using imaging in a more deliberate, intentional way for a number of diseases like breast cancer, lung cancer, and in fact, even for prostate cancer more and more. We have a number of biomarkers that allow us to find the cancer early, PSA in the context of prostate cancer. And we know that early detection saves lives. We have much better therapeutics at our disposal, such as immunotherapy, which have changed the landscape of how we treat and manage cancer today. But if we're being completely honest, at least one of the reasons for this discrepancy between the 40% diagnostic rate among all adults in the US and 600,000 deaths per year, certainly at least one of the reasons is the fact that we are over-diagnosing and over-treating a number of cancers today. And perhaps nowhere is this more exemplified than in the context of prostate cancer, a disease that affects 1 in 7 men in the United States and yet will only kill 1 in 40 men. Again, I don't need to trivialize the fact that 1 in 40 men diagnosed with prostate cancer will end up dying because of the disease. But again, you see the disconnect, right? So 1 in 7 that will have a diagnosis of prostate cancer, and yet it's something like 5 times or 6 times that number that will, probably die on account of something else, even though they've been diagnosed with prostate cancer. And yet, even though prostate cancer continues to be diagnosed fairly frequently, even though we acknowledge readily that it's a fairly indolent disease, we end up treating prostate cancer very aggressively. We continue to use prostate surgery. We continue to use radiation therapy as the primary methodologies for treating prostate cancer, even knowing that these are fairly aggressive treatments. We know that prostate cancer is a fairly indolent disease, and using radiation, using surgery does have deleterious side effects. We know that there is a non-zero mortality associated with prostatectomy, that is prostate surgery. We know that radiation therapy can lead to other cancers. So even though you're treating prostate cancer with radiation therapy, I think in 2 to 3% of prostate cancers treated with radiation therapy, inevitably there is additional cancers that occur on account of the primary radiation treatment for prostate cancer. And so one cannot deny the fact that the aggressive treatment of a fairly indolent disease does come with ramifications, does come with toxicity. And in the United States, one of the additional considerations that we have to be honest and we have to acknowledge is the fact that there is a very real issue of financial toxicity. It's not just the toxicity to the patient because of aggressive treatment. There is also the very real issue of the fact that many cancer patients in the United States will lose their life savings because of that cancer diagnosis. And we have to acknowledge the fact that overtreatment, overdiagnosis is very directly responsible for at least some of these cancer patients who end up going bankrupt because of that cancer diagnosis. However, if you think about cancer today, one of the things that we do know is that there's a lot of data that we are routinely acquiring during the workup of a cancer patient. In other words, inevitably a patient will get an imaging scan. Ultimately, the diagnosis of cancer continues to be with histopathology, so typically through a biopsy, which results in a tissue slide that is looked at by a pathologist. And so for any cancer patient, certainly for a lot of solid tumors today, you're routinely looking at both imaging data as well as pathology data. And all of these various different modes of information, modes of data are being routinely acquired for a given patient. However, the fact is that we are leaving a lot of the really critical information on the table. In other words, even though this information is used to render a primary diagnosis, there is a lot of information that resides within the radiology, within the pathology, that could really enhance our fundamental understanding of the aggressiveness of the disease, of the disease course. In other words, this disease-specific information that really spans different length scales from the radiology to the pathology could really help address questions beyond just the diagnosis of the tumor. In other words, we could be looking at the use of this information to predict disease outcome, to predict progression, to be able to predict therapeutic response. And it's really the development with artificial intelligence of tools that go beyond diagnosis to be able to prognosticate, to be able to predict treatment response, that ultimately will allow us to really realize the promise of precision medicine, which is to tailor the therapy for a given patient based off their specific risk profile. So artificial intelligence coupled with this routinely acquired data, radiology, pathology, could really help unleash so much more latent information that's embedded in the data that visually we are not able to appreciate, that a radiologist or pathologist, no matter how well trained they are, can simply not pick up the richness of the information that's embedded in the image data. And so all of this begs the question, what exactly is artificial intelligence? What really are we talking about? And today, I think we tend to think about artificial intelligence somewhat synonymously with deep learning. So deep learning, it must be said, is a particular kind of machine learning methodology, which has been around for a long time, right? It's been, the deep learning is really a advanced way of doing neural networks. And neural networks, of course, have been around since the late 50s, the early 60s. And so we know that neural networks are a way of representation of data. In other words, you've got a series of different neurons that are connected in different ways. And as you pass the data through these neurons really serve as ways to encode the information in the primary data. But what has happened over the last 10 years is that we've been able to take stacks of neurons and connect them in various different ways. So we're able to create very complicated, sophisticated architectures of neurons to create very, very deep networks, and hence the term deep learning or deep neural networks. And the advantage preferred by these deep neural networks is the fact that without having a deep domain knowledge of the particular disease that you're studying, you can simply provide the data to the deep neural network with annotations of the targets of interest. And the network can then learn the appropriate representations from the data. So the network can now start to figure out what are the particular patterns associated with a nucleus or a cell in an image. And having learned those patterns, which are then encoded via the neurons within the deep learning network, in the context of a new example, a new image, the network is able to associate those patterns with this new target. So if you learn the patterns, of the network learn the patterns associated with the cancer cell, it is then able to correctly identify or accurately identify where those particular patterns reside in the new image. And so it was a game changer in the context of medical imaging particularly, because a lot of people who really did not have any knowledge about pathology or radiology were able to take annotated images provided to the network and then use the network to start to learn representations, to start to learn patterns, and start to apply it to new images, and were able to diagnose disease, were able to diagnose cancer, et cetera, without really having any fundamental understanding of the disease, without having a fundamental understanding of the pathology or the domain that they were applying these algorithms to. Now, the reason why this works is because with the annotations, the networks are able to learn patterns in a way that's fairly abstract. So in other words, the human being may not be able to truly appreciate what these representations mean, but the network is really going through a process of trying to learn or estimate those representations that best distinguish the target of interest from everything else. And as it is doing that, it is learning representations that are fairly abstract and also hierarchical. So you're learning in a very sequential way representations that are just make no sense whatsoever to the human the human observer. But in a very systematic way, these deep learning networks are able to create hierarchies of abstract representation. And so that is certainly the advantage, but it's also to some extent the critique that is often leveled at these deep learning algorithms. They're often called the black box or the mysterious machine, because those representations that are encoded by the deep learning algorithms are just abstract for the human observer. However, there is another alternative. And the other alternative is to really try to find ways in which one can phenotype the image. In other words, use machine learning to really go in and very systematically interrogate different targets, different regions within an image, and then try to identify patterns from the image that are more tethered to the pathobiology of the disease. In other words, really find those patterns that are linked to the domain-specific knowledge or domain-specific information associated with the disease. So in this particular example, you can see how machine learning could be used to look at a chest CT scan and segment out the tumor, segment out the vessels, segment out the parenchyma, And one can then pull out what are called radiomic features, or radiomic patterns that really capture attributes that are very deeply tethered to the pathobiology of the disease. In other words, looking at the heterogeneity of the tumor, looking at the shape of the tumor, looking at the twistedness of blood vessels associated with the tumor, features that are more interpretable. And so this is a concept of radiomics or deep phenotyping of radiology scans. And the same approach could be applied to pathology images or biopsy images, where machine learning could be first used to identify the cells of interest or the tissues of interest. But then by using deep phenotyping for pathology, we could start to look at the spatial arrangement and the spatial architecture of different cell types, like immune cells, like cancer cells, look at their particular geographic location in different tissue compartments in the stroma and the epithelium. And by looking at the spatial architecture of these different cell types with respect to each other within different geographic compartments, we're able to convert the data into a series of quantitative features or quantitative measurements that we can then start to associate with outcome, that we can then start to associate with treatment response. And so what our group has been doing really over the last 10 years or so is trying to see how we can pull these features both from radiology images as well as pathology images, and across a variety of different diseases. What you're seeing here mostly is in the cancer space. Try to connect these features to treatment response across a variety of different treatment types. And so I'm not going to read out all the data that's on the slide, but you can see on the extreme left, multiple different cancer types that we looked at: lung, endometrial, ovarian, cervical, gynecologic, breast, rectum, multiple different categories of treatments like immunotherapy, chemotherapy, combination therapy with chemo and immunotherapy, trimodality therapy, CDK4/6 inhibitors, targeted therapy. And so a large number of different combinations where the use of these features can really allow for prediction of treatment response. And that is really important because from a clinician standpoint, the important question is, how do I treat this patient? What kind of combination do I need? Should I leverage for this given patient? And we know that in many, many different treatment types, the response rate is very, very poor. We know that for chemotherapy, immunotherapy, the response rate can sometimes be something like 20 to 30%. And so these response rates really mean that we need to do better in predicting in advance of therapy as to which patients are truly going to respond and which patients are not going to respond. For those of you interested in learning more about this, I refer to you to a paper that we published about a year ago in Nature Reviews Clinical Oncology that talks about the use of this sort of deep phenotyping approach for outcome prediction and treatment response using AI with radiology scans. And so please feel free to take a look at that. But what I'd like to do is really go through some concrete examples with you over the next 35, 40 minutes so that you can really appreciate how these tools could be used in a very translational, impactful kind of way. Let's first start off with breast cancer. One of the big questions in early stage breast cancer is figuring out which patients with breast cancer should be getting chemotherapy and which patients can avoid chemotherapy because they may not receive added benefit from it because they are going to do fine with surgery and hormonal therapy alone. Now, about 2 decades ago, a gene expression-based test called Oncotype DX was developed by Genomic Health. And the test was a game changer for the treatment management of breast cancer patients because with this gene expression-based test, the test was able to identify which patients had a low risk score, meaning that their cancer was fairly indolent, versus patients with a high risk score, which meant that those patients were going to have more aggressive disease and therefore were probably going to benefit from additional chemotherapy. And so this test was a real game changer, but it came with some caveats, it came with some challenges. One of which is the fact that these tests tend to be pretty expensive. They cost something like $4,000 per patient. They are tissue destructive, but critically, they are also not immune to intra-tumoral heterogeneity, which means that when these genomic tests profile the tumor, they're only taking a small piece of the tumor. And because they take a small piece of the tumor, the component that is profiled for genomic sequencing may not adequately reflect the most aggressive component of that tumor, right? So intratumoral heterogeneity, we know, is a reflection of the aggressiveness of the disease. In other words, the more heterogeneous the tumor, the more aggressive it is likely to be. And what that also means is that you've got multiple subclones. And so if you end up profiling a subclone that does not represent the most aggressive component of the tumor, the risk score you get may not be a true reflection of the true aggressiveness potential of that particular tumor or that particular patient. However, on the other hand, the use of pathomics really has provided an alternative or a complement, if you will, to genomic-based tests. Pathomics really is a term that refers to the extraction of image features from pathology images. So you can take a routine H&E image, and by application of image processing, computer vision tools, machine learning tools, one can, like I said, really deeply phenotype these images. You can start to look at a series of different patterns from these images that represent quantitative digital biomarkers that allow for predicting outcome and treatment response. And so our journey in this area of pathomics really began about 13 or 14 years ago when I had the good fortune of meeting with Dr. Sridhar Ganesan, Dr. Michael Feldman, and Dr. John Tomaszewski at the Cancer Institute of New Jersey and the University of Pennsylvania, respectively. And so working in tandem, we came up with this concept of the image-based risk score. And the basic idea was to look at digital images of glass slides or biopsy slides, and using pattern recognition machine learning algorithms to tease out features from these slides that we could then associate with treatment outcome, treatment response. And the beauty was that by developing this test, we were not destroying any tissue. We were not actually changing the current clinical workflow for pathology, right? Because as part of routine workup for these patients, a biopsy is always done. Glass slides always generated. The only additional difference was that we were digitizing these glass slides, and digital pathology now has become fairly widespread. A lot of different centers, academic medical centers and otherwise, routinely digitize their glass slides. So the fact that we've got these digital images means that with a cloud-based implementation or a computer algorithm, you could run these tests on the digital images and generate a prediction of outcome in a way where you did not destroy the tissue, and you could do it for much, much lower cost. But our focus, like I said, was really on developing interpretable features. We wanted to get away from the black box and really focus on features that were more intuitive, more transparent, more interpretable. And so what I'd like to do over the next several slides is give you examples of where we've been developing features or patterns that are really tethered to the pathobiology of the disease. So I want to start off with one example in the context of breast cancer. This is work pioneered by Dr. Haojia Lee, who was a graduate student in my group. And Haojia used a machine learning approach to go in and look at collagen. So collagen, of course, is a protein and present in a number of different tumors. And the role of collagen is getting a lot of interest. I'd say over the last several years, it's been getting a lot of interest as a cancer promoter. And so we wanted to see whether we could look at a routine biopsy image and evaluate the architecture of collagen and try to associate the architecture of collagen with outcome. And so what we did here was to use machine learning first to segment out the collagen, and that's what you see with the blue lines. We then segmented out the tumor areas and then looked to capture the orientation of the collagen fibers with respect to the tumor regions. And having done that, we then borrowed an idea from high school physics, namely the concept of entropy. And the concept of entropy is really interesting because it allows one to capture the relative disorder or order in the system. So essentially, this approach allowed us to capture the relative disorder on account of the collagen architecture in these pathology images. And what we observed was that in those patients that had short-term survival, the collagen fiber architecture was very coherently organized. However, in those patients where they had better outcome, they had long-term survival, there was more chaotic arrangement of the collagen fibers. And so what we found was that when we looked at this entropy feature, the entropy feature turned out to be strongly prognostic of outcome in breast cancer patients. So if you look at these curves, these are called the Kaplan-Meier curves or the survival curves. And the fact that we could see very clear distinction between these curves means that this biomarker did a really good job in predicting what the outcome for these patients were going to be. We were able to predict risk of recurrence. We were able to predict risk of survival. in overall survival in these patients. And the beauty was that we were doing this solely based off collagen fiber architecture from routine biopsy images. And it's not just collagen. We've actually been able to look at a series of other features relating to arrangement of individual cells, looking at the number of tubules in an image, looking at the number of mitotic figures in an image. And combining all of these features, we've been able to demonstrate an association with outcome across multiple different sites. So we looked at patients treated in Cleveland, patients treated on clinical trials, patients treated even in India at the Tata Cancer Center in Mumbai. And so what you see here is that both for early stage lymph node negative breast cancer as well as later stage lymph node positive breast cancer, that these image features have been able to clearly distinguish the two different risk groups, the poor survival from the worse survival, and that we've been able to demonstrate the utility of these approaches across multiple different sites, both for lymph node negative as well as lymph node positive breast cancer patients. Now, what is really exciting, the most exciting piece of data that I want to share with you is this data, where we look specifically at patients who had the low Oncotype DX score, as well as the high Oncotype DX score. So if you recall, low Oncotype, of course, refers to a low risk score, suggesting these patients don't need chemotherapy. But when we looked at those patients who had a low Oncotype score and we applied the IBRIS test, the image-based risk score assay, to the low Oncotype category, we found a very clear distinction between the low risk group in the green and the high risk group in the red. What that means is we were able to find a subset of patients who, even though they had the low Oncotype category, when Oncotype said these patients don't need chemo, we were able to identify a subset of patients who actually had really bad outcome and probably should, in hindsight, have received chemotherapy. Conversely, when you look at patients who had high Oncotype, remember high Oncotype is where patients all should be getting chemotherapy. Even there, we were able to identify a subset of patients who had low risk and therefore, in hindsight, perhaps could have avoided adjuvant chemotherapy. So what you would see here is that even though this is a very expensive test, that is the Oncotype DX test is very expensive, by taking the image-based test, which is much cheaper, we were able to add significant value, significant granularity to the predictions from the Oncotype DX test. And so this is my little head-to-head comparison. It's a little bit tongue-in-cheek, so you'll kindly indulge me. The question is, why does this matter? One is the cost of the test. The Oncotype is extremely expensive, over $4,000. The IBRIS test can be significantly lower in price, much faster because you're not shipping any tissue around. You're digitizing the images. You're not destroying any tissue. And of course, you've got a worldwide implementation as opposed to its use in the US alone, which is what you see with tests like Oncotype DX. In other words, you have an inexpensive, fast, reliable, accessible prognostic breast cancer test that's priceless. For everything else, there's miles to go. Now, it's not just in breast cancer, but it's in other cancers as well that you can see the utility of these approaches. One of the other areas we've been looking at is trying to predict post-surgical recurrence in prostate cancer patients. This was a study we published last year where we showed on a large cohort of patients that looking at patterns relating to the shape of the glands as well as the arrangement of the glands, that we could prognosticate which patients were going to have recurrence after surgery from patients who were not. And what was really interesting was that not only were we able to find utility in these patients in the independent validation set, but we were also able to see utility in patients who were margin negative. So these were patients where there was no evidence of tumor on the boundaries. And so typically these patients would have been designated as low risk. But even there, we were able to identify a subset of patients who truly had higher risk. And so this was a really exciting result. What was perhaps even more exciting in this paper was the fact that we went head-to-head with the Oncotype DX equivalent in prostate cancer, a test called the Decipher Test. And so what we were able to demonstrate in this paper was that when we went head-to-head between the image-based risk score and the Decipher Test, that the image-based risk score was significant, was just as good as the Decipher Test in terms of being able to predict outcome. However, when we took the image-based risk score and combined it with the Gleason grade or the Gleason score, as well as the prostate-specific antigen test, a biomarker for prostate cancer, when we combined those two additional variables with the image score, we found that we were able to do significantly better compared to the Decipher. Now, the Decipher is a $3,000 test. And so what was really exciting about this was that by combining image features alone, along with these two other clinical variables, we were able to do better than a $3,000 test. So that was very, very exciting. Now, one of the topics that I do want to touch on, which is something that I'm very, both I as well as our group are very passionate about, is really trying to understand health disparities. So we know that the patterns of the disease across different populations tend to be very different. If you look at South Asians, for instance, and Caucasian North Americans, we know that the incidence of disease like triple negative breast cancer is something like 2.5 to 3x more prevalent in South Asians compared to Caucasian American patients. Similarly, we know in prostate cancer that African Americans tend to disproportionately be affected, not just with prostate cancer, but more aggressive prostate cancer. Now, I want to quickly add that this issue of prevalence is a complicated one because it also has its roots in access. And of course, access is another issue, which of course relates, if we're being completely honest, to racism and denial of access to care for a long time. But after compensating for social determinants of health, we also have to recognize that between different populations, there are also potentially biological factors that suggest that there are morphologic differences between the cancer phenotype across populations. And so in this study that we published a couple of years ago, we did a very systematic study between Black patients with prostate cancer and white patients with prostate cancer, and found that within the stromal compartments of the tumor, there were significant differences in the appearance of the disease. So what we did then was to take the particular differences that we'd identified and used it to train a tailored model specifically for Black men with prostate cancer, and found that when we had a Black population-specific model for Black men with prostate cancer, it turned out to be much more accurate compared to a population-agnostic model, right? So a population-agnostic model is one where we ignore the differences. And unfortunately, that model turned out to not be prognostic in Black men. But when you identify the particular differences, particular morphologic features associated in the prostate cancer in Black men, that particular classifier turned out to be more accurate. And this really suggests that we have to do a better job in making sure, as we develop our AI algorithms, that we're being intentional and deliberate to make sure that we're accounting for different populations and that we're making sure that there is a representation in the training sets, in the discovery sets, as we're developing our AI tools. One of the other things that I try to emphasize when I talk about AI is the need not just for a large amount of data, because very often when you hear about AI, people talk about the need for a lot of data. I would actually argue that if you develop your AI in the right way and use the right features, it's not always about having a lot of data. It's about really validating your approach on many sites, on many different labs, in data coming from different institutions. That probably is more critical than just having a lot of data to validate your assay on. So here's an example of work that we published last year in the Journal of Clinical Investigation, where we developed what we called a multinucleation index. So essentially, it was a prognostic hallmark of oropharyngeal cancers that we were very, very interested in. So P16 positive oropharyngeal cancers or head and neck cancers are relatively indolent cancers. So patients who tend to get these cancers in general tend to do well, but a subset of them will not do well. And so what we wanted to study here was a particular feature that had been identified in the pathology literature a while back as being implicated in poor outcome. And so specifically what we did was to develop a machine learning algorithm to go in and find this hallmark called multinucleation. Multinucleation is where you see this aggregate of large cancer nuclei that are coalescing with each other, that are intersecting or touching upon each other. And so when we developed this machine learning algorithm, we were able to go in and find the multinucleation on these whole slide images, these pathology images fairly rapidly and created an index, a multinucleation index. And you can see that equation here. But basically, it was a count, a normalized count of how many multinucleations there were on the pathology image. And we showed that just the count, just this normalized count of multinucleation, did a really good job in prognosticating outcome in oropharyngeal cancers and head and neck cancers. And you can see the data here. There's a lot of data. I won't go into every piece of data. But what you can see here in stage 1 and stage 3 head and neck cancer is that multinucleation really separated out those patients who had good outcome from those patients who had poor outcome. Now, that was not the only feature that turned out to be important. Another feature that we investigated had to do with the spatial arrangement of immune cells on pathology images. So specifically, we looked at the arrangement of so-called tumor-infiltrating lymphocytes, or TILs. And these tumor-infiltrating lymphocytes, or TILs, we were able to exploit the fact that the particular arrangement of these cells tend to be different in patients who do well and from patients who do poorly. And so we did a large systematic study that ended up being published in the Journal of the National Cancer Institute earlier this year, where we showed that looking at this spatial arrangement of the immune cells on biopsy images allowed for prognosticating disease-free survival in head and neck cancer patients in a way that was independent of all the clinical pathologic factors. Now, one of the obvious things you would ask is, well, what if you combine different biomarkers? And so this is work where we did exactly that. We took the multinucleation index and we took the spatial arrangement of immune cells, combined the two, and showed that in combination, we could prognosticate outcome even better. And so this is the data that shows on I think, over 700 patients that the combination actually does do better. And so this data is from multiple different sites, multiple different institutions. And you can see here very clearly that there's a very clear separation between patients who do poorly from patients who do well. Multiple other examples where these tools can really play a role. This is from work that we published last year, where we showed that the image-based risk score, specifically looking at the spatial arrangement of the immune cells, was not just prognostic of outcome, but specifically added value for patients who were receiving chemotherapy. So in other words, just like in breast cancer, we were asking the question as to which patients were going to benefit from chemotherapy from patients who could avoid chemotherapy. And so the findings that we published in this paper showed very nicely that when you looked at patients who got surgery alone, that the image score could find a subset of patients who were going to do poorly and therefore could have benefited from chemotherapy. On the other hand, when you looked at patients who received surgery and chemotherapy, the image classifier was able to identify a subset of patients who perhaps in hindsight could have avoided chemotherapy altogether. So in other words, not only is the test prognostic, it was also predictive for added benefit of adjuvant chemotherapy. What about other kinds of treatments like immunotherapy, which is what I mentioned earlier? And that was the basis of a paper that we just published very, very recently in June, in fact, of 2022, so literally about 2.5 months ago, where we showed that the spatial arrangement of the immune cells on these biopsy images was strongly associated with outcome, with survival, particularly in immunotherapy-treated non-small cell lung cancer patients. So what we were able to demonstrate here quite nicely was the fact that when you looked at the spatial arrangement, spatial architecture of individual cells and immune cells on these biopsy images, that those features were associated with response to immunotherapy in the context of lung cancer, and that this response was prevalent. You could see this strong response across multiple different sites. So we looked at data from multiple different sites. And in fact, it wasn't just in the context of lung cancer, it was also in the context of gynecologic cancers, such as ovarian, endometrial, as well as cervical cancers. What was also really exciting about this data was the fact that when you look across multiple different treatment modalities, that the signal that we got clearly showed association with outcome independent of the particular type of immunotherapy drug we were looking at. So regardless of whether you looked at atezolizumab, pembrolizumab, or nivolumab, that you would see the association with outcome. what was perhaps most exciting of the data that we showed here was the fact that when you looked at patients who had low PD-L1, so just to give a little bit of context here to those of the those members of the audience who may not be familiar. Now, PD-L1 is a biomarker for really helping identify which patients are going to benefit from immunotherapy or not. PD-L1, unfortunately, is not a very good biomarker. And so there are a lot of patients who have high PD-L1 who don't do well. And there are patients who have low PD-L1 and yet potentially could do well. And so high PD-L1 typically is the basis for deciding whether or not to give patients immunotherapy. If you have low PD-L1, you may not get immunotherapy, or even if you do, you may end up getting a combination of immunotherapy and chemotherapy. And like I mentioned before, chemotherapy tends to be very toxic, and you really want to try to avoid chemotherapy if you can. What we showed is that if you look at patients with low PD-L1, that we could really distinguish patients who were had favorable outcome from patients who had worse outcome. So what was exciting was if you look at the patients who fell on this yellow curve, that this suggested that these were a subset of patients identified by the classifier who could potentially avoid chemotherapy and might be candidates for just immunotherapy alone. Now, remember, the status quo would be to give these patients a combination of immunotherapy and chemotherapy. But what our data was showing is that these patients potentially could have avoided chemotherapy in hindsight. I'll just keep, in the interest of time, I'm going to sort of skip over some of this data because I do want to talk about some of the work we've done in radiology. And specifically, I want to introduce a feature that a radiomics feature, a radiomics biomarker that was developed in our group called Collage. So several years ago, we were looking at the problem of trying to distinguish radiation necrosis from recurrent tumors on MRI scans. And one of the big problems in patients with brain tumor who get treated with chemotherapy and radiation is when they come for a follow-up MRI scan, something inevitably shows up on the MRI scan. It's very difficult to tell whether it is an effect of the chemotherapy radiation called radiation necrosis, or is it a recurrence of the tumor. And because it's very difficult to tell on the MRI scan, many of these patients end up getting a biopsy. They end up having to go through another intervention. And obviously that's really challenging because you're talking about drilling a hole through the head. And what we were able to do was to use image processing computer vision tools to identify the dominant edge on a voxel by voxel basis. Similar to the work I showed you with the collagen fibers, we were able to learn the dominant orientation of the individual edges on a voxel by voxel basis. And then again, using the concept of entropy, we were able to create color maps like this. And so high reds represent high entropy. High entropy is a lot of disorder. Blue means very low entropy, relatively low amount of disorder in the system. And so it turned out that high entropy was associated with recurrent tumors, low entropy was associated with radiation necrosis. And so even though you couldn't tell the difference on the original MRI scans, here, by looking at these entropy maps, we were able to really distinguish between recurrent tumors and radiation necrosis. Now, this approach has been applied to a plurality of different problems, and I'll just show you some examples. This is work we published a few years ago, where we showed that looking at radiomic patterns outside the tumor on a CT scan could really distinguish which patients were going to have an adenocarcinoma, where they had a malignancy, versus patients who had a granuloma, which is a benign nodule. And so this, again, is a very challenging problem on CT scans, but again, looking at these patterns, both inside as well as outside the tumor, we could do a much better job in distinguishing granulomas from adenocarcinomas. One of the other features that we've also been looking at has to do with the twistedness of the vessels associated with the tumor. So radiologists typically tend to look at the tumor or the nodule, and based on its shape, based on its appearance, they make a diagnosis. The breakthrough that our group made a few years ago was the discovery that if you looked at the twistedness of the vessels associated with a tumor, that one could do a really good job in being able to distinguish the granulomas from the adenocarcinomas. And you can see a very high degree of accuracy that we were able to pull out in terms of distinguishing these granulomas from adenocarcinomas. One of the other things that we were also able to do was to predict pathologic complete response to neoadjuvant chemotherapy in breast cancer patients. We looked at MRI scans of these patients, and looked at these entropy features, these collage texture features outside the tumor. And what we found was that the overexpression of the entropy outside the tumor was strongly associated with pathologic complete response. So these are patients who undergo chemotherapy first and then undergo surgery of the tumor. And what we found is that if there was an overexpression of collage outside the tumor, those patients tended to not have any residual cancer on surgery. On the other hand, if you had an underexpression of collage on the outside of the tumor, then those patients typically tended to have residual cancer when the surgery was done. That is, the chemotherapy was not as effective. So this was really exciting because it provided a way of really connecting these image features to pathologic response. A number of other areas where we've applied these approaches. This is in the context of predicting outcome for, again, head and neck cancers, but this time of CT scans, not the pathology images. We've also showed that these radiomic features on the CT scans are associated with benefit of chemotherapy in these HPV-associated oropharyngeal carcinomas. We've also shown that the shape of the prostate can play a significant role in terms of outcome. So we've actually shown that if you look at patients who have recurrence of prostate cancer from patients who don't have recurrence of prostate cancer, and you look at the difference in the shape of the prostate glands between the two populations, we were able to show that there were clear differences in the shape of the prostate. So the shape of the prostate could itself provide an indication of which patients were likely to have recurrence from patients who were not. As I spoke about before, in the context of our pathology work, we've also shown that the application of these entropy features on CT scans could predict response to immunotherapy in the context of non-small cell lung cancer patients. This was a study we published in 2019 in the context of patients who were receiving immunotherapy in the second-line setting. We followed that study up with a paper that we published earlier this year, where we looked specifically at stage 3 non-small cell lung cancer patients. These were patients who routinely get chemotherapy, radiation, followed by durvalumab. Durvalumab is an immunotherapy agent that is marketed by AstraZeneca. And what was exciting was that in these patients, we were able to tell as to what their outcome was going to be, what their survival was going to be. We were able to tell as to which of these patients were going to respond to this triplet of chemotherapy, radiation, and durvalumab versus patients who were likely to not respond. And just as I showed you with the data in the context of our pathology images, similarly, we were able to look at the utility of these features both in patients with low PD-L1 as well as in the context of high PD-L1. And so again, you can see clear distinction between the risk groups identified by the image-based radiomic features, both for low as well as high PD-L1. So again, suggesting that these features could really play a predictive role, potentially identifying patients who may not need durvalumab or who might potentially benefit from radiation and chemotherapy alone. I talked about the vessel features, the tumor-associated vasculature. This is from data that we just published in Clinical Cancer Research just a couple of months ago, where we showed the twistedness of the vessels were associated with response to chemotherapy. The smoother the vasculature, the better the response. The more twisted the vasculature, the worse the response. And this was in the context of chemotherapy, but in a paper that we just found out today has been provisionally accepted in Science Advances. We've shown that the twistedness feature also plays a role in response to immunotherapy. More twisted, worse the response to immunotherapy. Less twisted, the better the response to immunotherapy. And finally, just to end, we talked about radiology, we talked about pathology. What about putting them together? And so, in data that we presented at the ASCO meeting last year, a little bit this year as well, we demonstrated that the combination of radiomic patterns from CT scans coupled with image features from pathology, the coupling of those sets of features allowed for better prognostication of outcome compared to radiology alone or pathology alone. And so with that, I'd like to end. So hopefully what I've conveyed is that computational analytics with routine imaging can help address questions in precision medicine. I really want to highlight the importance of the low-cost aspect of these tools. And that's really critical in the context of low and middle income countries where you're really looking for solutions that can help in better risk stratification, but you want to really look at tools that are not going to break the bank, right? So they've got to be low cost. I also hopefully conveyed the importance of looking at the intuitive basis of these features, the importance of really understanding what these features mean, and getting away from the black box aspect of these AI approaches. So with that, I'd just like to end, and again, just a quick shout out to the amazing group of students, trainees, postdocs, faculty colleagues that we have in our group. For those of you watching who are working in this space, who are interested, we're always looking for talented individuals to join our group. We've got a number of different openings. We've also been very fortunate to have been the recipients of a number of grants. In fact, I think as was just mentioned at the start of the talk, we actually just received 2 large grants from the National Cancer Institute last week. So if you're working in this area, if you're interested, please do feel free to reach out, because we would absolutely love to find more people who are passionate about this area and want to learn about AI and start to apply AI for problems in precision medicine. Again, if you'd like to get in touch with me, that's my Twitter handle. Thank you very much.
Wow, Dr. Madabhushi, what a wonderful, wonderful presentation. Thank you so much. Your talk and your presentation was so fascinating, and it was amazing to be able to learn so much more about AI and its use in pathologic oncology. Truly so amazing. And I'd like to thank you again for such an amazing presentation. So I'm sure our audience is quite excited right now to be able to discuss lots of different questions with you. So now I will be passing the mic over to Madhuri, who will be continuing on with the next portion of the session.
Thank you so much. Thank you everyone for joining us here today. Thank you for this amazing presentation, Dr. Anant. And it was really interesting to know so much about AI and where it's leading right now in the current future. And first of all, I'm going to welcome everyone to Discussions with Global Leaders. I am Madhuri, and we are really excited to be speaking with Dr. Anant Madabhushi, who is the Director of AI and Precision Medicine at Case Western University, as well as part of the Emory Winship Cancer Institute. We have received lots of questions, and we'll definitely do our best to get through all of them in the time we have available with you. And right now, for the first question, I'm going to be passing the mic to Muskan.
Yes, doctor. So my question to you really is, so as we know that the incidence of colorectal cancers in people between the ages of 29 to 30, 20 to 39 has actually increased significantly in the recent years. So with the screening and the risk stratification being one of the most important aspects of proper clinical management, I am interested to hear if you have observed any significant advances in the use of AI and the application of AI in the advances and the diagnosis of colorectal cancer. So I would love to hear your thoughts on this.
Yeah, thank you. So I think that with colon cancer, you're absolutely right. There's been a dramatic increase in in the number of colon cancers that are being identified. But it becomes important to also take charge of yourself. You get to a certain age where it becomes really important to go for regular screenings. Getting colonoscopies, for instance, is recommended. I think in your late 30s, early 40s, getting colonoscopies to make sure that there are no polyps. That is an area where there's a lot of interest in artificial intelligence. I think it was Medtronic that developed a tool with AI on colonoscopy images to really help in identifying whether a polyp is potentially benign or malignant, really helping to direct biopsies. There's a lot of work that's happening in our extended group on looking at particularly colorectal cancer patients to try to identify which of these patients might avoid surgery. So for late stage colorectal cancer, the current treatment regimen is giving them chemotherapy, radiation, followed by surgery. That trend is changing a little bit now because a lot of patients are also getting immunotherapy. But unfortunately, in the US, a lot of these patients end up getting surgery, and that is very debilitating because you're talking about a very, very traumatic surgery. And so one of the things that we have been looking at in our group is the use of AI with MRI to try to identify which patients might have complete response to chemotherapy and radiation and therefore could avoid surgery altogether. So a couple of different opportunities there. One, like I said, is AI with colonoscopy for helping in better screening. Better screening, earlier detection, identification saves lives. But then in the context of post-diagnosis of colon cancer, colorectal cancer, I think there's a lot where AI could really play a role in helping to change the treatment paradigm, the management paradigm. Not everybody needs to necessarily get surgery. Could be potentially identify the subset of patients could avoid surgery.
Thank you, Dr. Madabhushi. So we'll be moving on to the next question.
Thank you so much for that one amazing answer, Doctor. And right now, I'll be passing the mic to Dr. Yan for the next question.
Thank you so much. Thank you for that wonderful presentation. Now, given the complexity and the heterogeneity of cancers, how can AI technology account and/or anticipate future changes and really apply it to enhance diagnostics and therapeutics to ultimately improve patient care down the line? Thank you.
Yeah, that's a great question. It's a complicated question. And the approach that we've been taking in our work has been to take a very deliberate, intentional approach. So, there's a number of papers that I've seen come out recently, which claim that AI in a pan-cancer way can address all the problems, that you can prognosticate outcome, predict treatment response, and you just have this neural network and just pass enough data to it and it'll learn everything. Perhaps it's my training as a biomedical engineer, but I just tend to be naturally skeptical of things that I don't understand. And so the approach that we tend to take has been to look at each one of these diseases and really try to understand what are the hallmarks of the disease. Now, we tend to be very dismissive of radiology, of pathology, and we say, we've got the AI is going to take care of everything. Let's not forget that for pathology, for instance, you've got 100, 150 years of brain trust there, right? Pathologists have been looking at slides under a microscope for over 100, 150 years. There's a tremendous amount of knowledge and accumulated wisdom that resides in these different diseases. And that, I think, to me, is a true opportunity, right? So how can we use that deep knowledge that has been acquired over so many different years to start to systematically analyze attributes of these different cancers? And so what I tried to show in the course of my talk was there is something to be said about intentionality in really trying to model the pathobiology of a given disease and start to learn features or attributes that we can then systematically associate with outcome, with treatment response. So I would submit that the way to really show that AI is going to move the needle forward is very carefully, very intentionally, very deliberately. You pick a particular clinical problem with a very clear unmet need, and then develop a solution that is going to be interpretable. Because one of the things that you have to recognize is that when you're talking about AI for prediction of treatment response or predicting outcome, where you're going to try to change therapy for a patient based on what your AI is saying, you not only need something that's really accurate, you also need to be able to convince the clinician that this makes sense. If you're going to simply say, well, trust me, don't give chemo because the black box said so, it's very unlikely that you're going to get a clinician to be willing to go along with that. And furthermore, it's going to be very challenging to get a patient to say, hey, the AI said, I can skip the chemo, so I'm good. I'm going to skip the chemo. We're talking about life and death decisions here. So to me, it's going to be something very deliberate, very intentional, and something that's transparent and interpretable as well. So that's sort of my, perhaps oversimplification of a very profound question that you posed. But I think it really has to be done. I think there's no quick fix. There's no free lunch. It just has to be done systematically for each disease, for each type of cancer. And you've really got to demonstrate that you have the data to back it up.
Thank you so much.
Thank you so much, Doctor. And that was a really amazing answer to such a complex question. Now, I'm going to be asking the next question. And mine is that with the public sentiment towards AI, how do we make them understand and further educate and inform them? And another question that I had was, with certain conditions that do not have a well understood progression, how can we create data or algorithm to overcome this obstacle?
Okay, so let's break it down. So you had two questions. The first is, what can we do to better educate, better inform AI, what AI is to the general public? I would argue that perhaps in the area of medicine, the area of diagnostics, not only do we need to help educate the patients, we also need to educate the physicians. And it comes back to my response to Jan's question about interpretability and intentionality. I think that what we need to really be able to do is to communicate what the AI is capturing. Because at the end of the day, the way I think of it, the AI makes a prediction, but the prediction is predicated on what kind of representations, what kind of features that AI algorithm has, right? So at the end of the day, it's really about those attributes, those patterns, those features that your system is able to pull out from your radiology images or pathology images. And I think that to me is where we really provide that interpretability, because if you want to communicate what your AI for prostate cancer outcome is doing, or breast cancer or lung cancer or what have you, you've got to be able to convince a physician, you've got to be able to convince your patient that the AI is not somehow coming up with some random prediction. It is coming up with this prediction because it found that the vessels of the tumor were convoluted, were tortuous, were twisted, or it was because of the shape of the prostate or the shape of the cell or the particular arrangement of individual cells. One has to be able to link these specific patterns, these specific features in communicating what the AI does. So I think that that's something that we tend to not communicate very well. When we talk about AI, it's this abstraction, it's this black box. A lot of us tend to fear it. But I think the more you de-opacify the black box, the more you make it transparent, the more it becomes clear what these features are, what these representations are. I think it helps demystify the black box. And I think it's also going to help us with clinical adoption. It's also going to get us to a point where both the physicians, the payers, the patients, the providers are going to want to be using these tools for managing treatment and care. Your second part of the question, I think, is a little bit more complicated. You talked about progression and how do we build these AI-based tools. The fact is that to build these AI tools, we need ground truth. We need to know clinical outcome. We need to know what happened to these patients. And that can be a challenge in the context of certain diseases. Prostate cancer is a classic case in point, where if you wanted to develop a classifier to predict mortality of prostate cancer patients, the challenge is that you've got to wait 20, 30 years. And that becomes a challenge with a lot of diseases where the lifespan, because the cancers are so indolent, one can live for a very long time with these cancers. Thyroid cancer is another case in point, where thyroid cancer in general tends to be very indolent. So it can be a challenge for some of these more indolent diseases to be able to get the sufficient cohorts with the follow-up time, with the longer-term clinical outcome to really be able to develop these assays. So that's where collaboration, I think, really comes into play, being able to work with multiple institutions, getting out of your silo, trying to find partners across the world. That's something that we've really relished, we've really enjoyed. I can tell you that our group, we've partnered with folks in Finland, to people in India, to people in Uganda and Tanzania, because there are unique problems all over the world. And if you're looking at targeting some unmet need, it may be that those data sets, the problem that you're trying to solve, those data sets are not just next to where you are, but maybe you've got to go somewhere. But in taking the initiative, creating those collaborations, I think is going to be a very important piece of the success of AI. It's going to take the proverbial village for us to really, in a widespread way, be able to really push these algorithms out and get them adopted.
Thank you so much, Doctor, for that really amazing answer. And I think we'll be passing the mic for the next question to Gayatri. Hello, Doctor.
I believe there's an issue with the pathway.
I think because let her fix her technical issues, and I think Bill, you will move on to you right now.
Yeah, sure. Sounds good. So you're actually Dr. Madabhushi. First of all, thank you. This is a really interesting talk. But you were talking a little bit about the black box, and I was sort of curious. Are there any concerns about creating weapons of math destruction? That is, algorithms or math models that are sort of like this proverbial black box that perpetuate inequality. And like, what have you done, if this is a concern, what have you done to mitigate risk?
Yeah, so I think your question was around ethics, was around risk of AI.
Yes,
Yeah.
in possible unintended outcomes.
Unintended consequences. Yeah. Gotcha. Yeah, I think that this is all the more reason I come back. Sorry, I'm making a shameless advertisement for my social media Twitter account, but I just did an interview with a magazine a few weeks ago that just got published over the weekend. And one of the things I recount in that particular article was an example of a black box AI that we developed about 4 or 5 years ago, which initially when we ran it on a bunch of cases, turned out to do spectacularly well. But then subsequently, when we applied it on a new set of cases, did catastrophically. And so it comes back to this point about intentionality, about transparency, about really understanding the parameters of the system for which you're developing the AI. It's a complicated ecosystem, and it is something that way more attention needs to be focused on. So you touch on a number of different topics in the context of your question. And there's the unintended consequences, which means that we need to understand the system, we need to understand the box, we need to understand what is going into it. But there's only so much that can be done intentionally and deliberately. I'd like to think that most people are not intentionally racist or intentionally biased. But there's a lot of implicit bias, right? I mean, we all suffer from implicit bias. And ultimately, when you talk about these AI algorithms performing in a particular way or being biased towards people of color or underrepresented communities, very often it is a reflection of the implicit bias in the development of the AI. And this is a topic that I think is getting a lot of necessary attention currently, where really thinking about very intentionally from the get-go, the kind of data sets, the kind of discovery sets that one has to develop to avoid these unintended consequences is becoming really, really critical. I gave an example of some of the work in our own group where we've taken a very deliberate, intentional approach to trying to understand how these AI algorithms would work across different populations. And I think I showed one example in the context of looking at black men, white men with prostate cancer. And when you took the population agnostic model, it didn't work well at all in black men with prostate cancer. It was only when you specifically incorporated features that appeared to be prevalent in African-American men that the model really started to perform reasonably well in black men. So it comes back to the point that unless we're intentional about the populations, unless we're really intentional and informed in how we're developing these training sets and these AI models, there is a big risk of implicit bias, and implicit bias can really have catastrophic consequences. So thank you for that question. And I think that it really speaks to not just having really smart AI developers, but really starting to engage ethicists and people with different perspectives, people who are looking at the legal implications of AI, we need to include people from multiple different perspectives in the development and the validation of these algorithms. Because the challenge is that if you only focus on the computer scientists and the bioengineers in developing these assays, there is the real danger that we're going to have this implicit bias. And we really need a plurality of expertise that are embedded in the development and validation of these tools to provide that sort of sanity check, to have that sort of person looking over our shoulder saying, okay, have you considered these different aspects? The good news is that the regulatory agencies are becoming more aware of this, are really starting to appreciate the importance of validating these tools in a much more comprehensive way and making sure these tools are really being validated across a diversity, a plurality of populations. Unlike in the olden days where you just provided some data, the FDA accepted it, and then you got the approval. Now I think they're getting more particular about what populations has it been validated on. If you're looking at diseases like lung cancer, has this been sufficiently validated on both men and women? And so I think that is really critical because you can also have gender bias, right, in the development of a lot of these algorithms. So this is exactly why it takes a village, and we've got to really think of developing these tools, not solely as being within the purview of the computer scientists, but really bring in, like I said, people with an ethics background, with a legal background, providing additional perspectives.
Thank you so much, Doctor, for that really amazing answer. And this is honestly really great to hear about. Now we're coming up to our last question for this session. I'll be passing the mic to Harshal.
Yeah. First of all, thank you, Dr. Madabhushi, for this insightful session. Myself, Joria Harshal from India. And my question is, what is one of your biggest career challenges and how did you overcome it?
What was my biggest challenge and how did I overcome it? I think my biggest challenge for me was that I met with a lot of skepticism in the early days. So I talked about the image-based risk score that I developed or conceived of about 13 or 14 years ago. And the idea was that we could look at a pathology image and based on that pathology image, find patterns that could tell us as to which patients were going to benefit from chemotherapy or not. And I could not get funding for this. I couldn't get people to believe that we could do this. I remember going and pitching this idea to people, and I was told that it was crazy. I had somebody literally tell me that they had a philosophical problem with what I was proposing. That is that I could predict the biology of the tumor from looking at images. And so it was this, I was, for a time I was frustrated. I was at a crossroads and I wasn't getting funding for this. I didn't really know what to do. And I had to make a decision as to, do I persist with this idea or do I just give it up and go in a different direction and do something else? Thankfully, I decided to persist with the idea, ended up spinning out a company, continued working on this area. The company subsequently got acquired. I went on to be very successful in getting grant funding for this work and have continued to be able to get grant funding around this work. The lesson I learned was about resilience. I just learned that you definitely want to listen to people, you want to get different perspectives, but you have to internalize and really think about whether the idea that you have, whether it is worth pursuing. And if you decide that it is worth pursuing and that you believe in it, then you have to be resilient. You have to be willing to take the blows. One of the things that I try to tell my students and trainees, I think it was mentioned, I think Muskan and Jan mentioned that I had a couple of grants that were awarded last week. And I posted it out on social media. I think very often when you do that, trainees or young faculty who are in the space, look at it and say, oh my God, some people just, it's so easy. It's so easy for them. They're so successful. it's so funny because 14 years ago, I was in that exact same space. I was looking at other people who were getting grants and saying, man, I just don't know how to do this. It is too difficult. It is too painful. These grants really came about because really of an accumulation of about 13, 14 years worth of work, of resilience of patients that just went into it, because I just felt like this was my passion play. This was something that I knew what made sense. I knew that I wanted to do this. As somebody who grew up in India, I knew that I wanted to develop technologies that were going to be relatively low cost, but could have a high impact in low middle income countries. And so just really persisted. So, it's not a very profound answer, but I'd say that just looking back, 13, 14 years ago, it's really just been about just continuing on, just taking the blows. There will be blows, but you have to be willing to take the blow and just move on. One of the other things I also like to tell my trainees is you think of it really as a marathon. You can't be thinking of it as a sprint. You got to be thinking of it as a marathon. And when you're running a marathon, there are going to be times when you're going to feel like you've hit the wall, and that's okay. But you just have to persist, and you got to be able to break through that barrier and just keep going. And I think ultimately at one point, it will start to fall together. It will start to come together, and you just have to be willing to keep pushing and keep going, and do the things that you need to. Right? I mean, it's not also just about the work. It's about work ethic and exercise and sleep and spending time with family and friends. I mean, it's a balance. So be passionate, but at the same time, take care of yourself, because you need that, right? When you hit that wall, it's these other things that are going to really help you get through that wall. So yeah, so my 2 cents would be, take care of yourself, be passionate, don't give up, and just be resilient.
Thank you so much, Dr. Madabhushi, for that really amazing words. And I think we're all going to be truly inspired by what you just mentioned and your experiences as well. Unfortunately, this is all the time that we have for today. And thank you so much to everyone who came here and for all the great questions, and to all our attendees as well.
Thank you so much. Really appreciate it.